gives me enormous pleasure to introduce Professor Anthony Kawaja. He's our latest arrival at Clinical London, where he is looking after patients with glaucoma and cataract. I would like to talk a lot about him, but I think what I'm going to do is just say that he is a star, and I want you to make up your own minds if you agree with me after you've heard his lecture. There will be the chat function, so you can send in queries and we'll present those to you probably at the end, but may we interrupt you as we go along?
Yeah, of course, yeah.
If it's really relevant, I think that'd be great.
Definitely.
And for those who are on Zoom, we've got about 100 people out there on Zoom, you'll be receiving a Zoom survey. And for those of you who are here in person, you'll get a Survey Monkey to do afterwards. So over to Anthony. Thank you very much.
Thanks very much, Jane. So as Jane said, I look after patients with adults with glaucoma and cataract at Moorfields Eye Hospital. I'm a professor of ophthalmology at UCL, where I research a lot of conditions, including glaucoma and the other common eye conditions, myopia, age-related macular degeneration. But today I'm going to talk about how can we collectively deliver good quality care for our glaucoma patients. You might have seen the objectives, and we'll work through all of those. Actually, the last time I think a lot of us came together to decide what does good quality glaucoma care look like, it was quite a long time ago. For quite a while, people said, oh, we're going to update this, Anthony, and we'd like you to lead it, but it still hasn't happened. But this was great because it brought together ophthalmologists, optometrists, GPs, pharmacists, patient groups, and so on to decide how best should we manage glaucoma. But clearly it can't still be up to date. And I think when we look for guidance about what's the best way to do it, one of the places we often go to is the European Glaucoma Society guidance, which is now getting quite old actually. And a 6th edition is actually in the works, and I'll come on to that. But one of the features of the 5th edition was we want it to be the very highest level of evidence that we present and inform the guidance. And that comes mainly from randomized controlled trials. So that's kind of the focus. And just to zoom out a bit, this is what EGS say, and I think we all agree. What is our goal when we're looking after glaucoma patients? Well, we want to make sure that their quality of life's maintained. It's not necessarily about saving every single nerve fiber. And because we've got to do that within a sustainable healthcare system. So we can't send everybody with maybe very mild forms or just suspected glaucoma and expect expensive care for them. So let's just start off with open angle glaucoma and ocular hypertension. So this study isn't new, but is still very relevant today and is still the best evidence we have for the treatment of glaucoma, the UK Glaucoma Treatment Study. And this is amazing that it took so long for us in the field to do a placebo-controlled trial. Up till this point, all of the proof for glaucoma wasn't against placebo. If you talk to cardiologists about this, they'd laugh at you. They'd never prescribe a drug that had a placebo-controlled trial. And this study showed that if you treat people with latanoprost rather than placebo, you halve the chance of their glaucoma worsening in a 2-year period. But if you look, actually, 3/4 of the people that had placebo didn't even get worse. So maybe we don't need to be treating everybody. And there's this famous EGS graph, which is who do we treat? Because if somebody, say person A, is somebody who's only going to get worse very slowly, they're never going to reach a point where their quality of life's affected before they die. If you've got someone like E, who is really getting worse very quickly, probably you would treat them no matter how old they were. Someone like B is getting worse quite quickly, but because they don't have that much life expectancy left, then it might not be worth treating them. Of course, it's very hard these days to work out how long your patient's going to live. I remember I used to congratulate all my 90-year-old patients as I was taking them into the room, whereas now that's every clinic, and it's the 100+ that I sort of congratulate when bringing them in. This is another way of thinking about it. Each dot is a patient in a glaucoma clinic in the UK, and how the dot's moving is how the vision's worsening in their right and left eyes. Basically, if you're a patient, you don't want to end up here, because it means you become blind despite being under care. And the problem is, we really need to be focusing our resources on those people and understanding how can we better manage these people. And clearly just doing that top corner in hospitals is not a good idea. So initial treatment, this has been one of the biggest changes, I would say, in the last EGS guidelines. And one of the big things that has changed is now when we first treat someone with ocular hypertension or glaucoma, we would consider selective laser trabeculoplasty, which you all know is a very simple, painless, quick procedure. And the reason that there's been this change really comes from one study which was led out of Moorfields called the LIGHT trial. These days, when you do a trial, you can't just say, oh, it lowers pressure as well, or it saves visual field as well. You have to look at quality of life. And so that's the main outcome. And actually, everyone thought, well, drops ruin your quality of life, right? They give you dry eyes, they irritate you. There'd be a difference, but there wasn't any difference, actually. But the real striking finding wasn't really the main thing they were meant to be reporting, but it was for those people that got treated with laser first, at 3 years and 3/4 were still drop-free and at a pressure level that the ophthalmologist was happy with. And actually, when you go out to 6 years, it goes down to only 70%, but some of them needed repeated SLT. So that was, people were really surprised by this result. It was likely to be more cost effective. There are other studies that have come out saying maybe the visual field gets less worse, maybe less needs surgery. So it seems as though for some people, laser is the better treatment. That result was so stunning, I think some people thought, well, that doesn't reflect my practice. It doesn't seem to work that well in everybody. So we looked at, well, what are the more realistic things you can tell your patients? Because that study, obviously you had to get into the study, and it's a special type of patient that enters those studies. When you look across, this is across 5 centres across the UK, looking at all comers who are having SLT, you can see that you get a good response initially in about 70% of people. So I tell my patients 3/4 chance you'll have a good response. But by 2 years, around 3/4 have needed some kind of additional treatment. So that's actually still a pretty good treatment. There are some people who will last a lot longer, but maybe that's a good way of setting expectations. And often having a repeat laser at that 2-year point can keep them going for quite a lot longer. Now, if all our patients were the same, they would have, this is the average treatment response. So pressure goes nicely down initially, and slowly over time, that effect wanes. But our patients aren't all. So these are the individual pressure responses. And you can see some people do amazingly well. A few people get worse. Their pressures spike up afterwards, and that's one of the risks of SLT. And then there's this whole range in between. So clearly, one size doesn't fit all, and we need to better work out who are the patients that will do better with laser first and who are the patients that will do better with drops first. And I'm not going to go into it today, but that's what some of my research looks at. But just to say, this is something that has been published now, looking at the LIGHT trial and showing one factor that does matter for this, and that's the baseline intraocular pressure. You've got a high, SLT works much better if the pressure's higher. It works a lot less well if the pressure's lower. And you can see here in higher pressures, SLT does better than drops. In lower pressures, drops does better than SLT. So that's just one way that we can start to work out, rather than treating all our patients as averages, how can you treat them so that you give them the treatment that works best for them? Now, this is something I gave input to that isn't used that much, which I think is a shame. It's an amazing leaflet. That's the QR code if you want. The NHS developed it, and it's a decision support tool that is in very basic language, not language that ophthalmologists or optometrists think is basic, because we get used to speaking a different language. So patients love it, and it helps walk them through so that they can be involved in the decision of, do I want to start off with drops or start off with SLT? One problem with drops, obviously, is adherence. We say adherence now, not compliance. Compliance is a bit rude. Our patient's not compliant with my orders. So how well, and adherence is difficult for multiple reasons, including how to put in the drops, and there are different techniques, and there are drop aids. And one thing I think we could do more of in the community, I'm sure the optometric community already take advantage of the Glaucoma UK patient information leaflets, but I think these are great, and point patients towards them regularly. And if there are any GPs online, please do encourage your patients to go to this, because every time I have to use eye drops, I just think, how am I expecting my 90-year-old patients to use this when I can barely do it myself? There's a whole range of leaflets. We've actually just helped revamp a lot of them. So in the coming months, there's going to be new updated versions of these leaflets, and I think they're brilliant. One particular one that patients get concerned about is about driving, and that leaflet's being updated too. So that's open angle glaucoma and ocular hypertension. There's been a lot, I would say, even perhaps more change for the narrow angles, the angle closure disease, which is a spectrum. And in the community, this is often identified, this anatomical predisposition doing the Van Herrick test, which is an excellent test if done well. And I would say if it's as narrow as this on a Van Herrick, it's pretty much always narrow on gonioscopy. Sometimes the Van Herrick will miss something if you've got an anteriorly placed limbus. And gonioscopy, according to the EGS guidelines, and I think most of us, is still the gold standard. And that's because with anterior segment OCT, it's actually very hard to know where trabecular meshwork is, to know if iris is resting against it. You can't always tell. The classification of this, still the most modern one that's best, was made in 2002. I don't like the terms. I think it makes it sound more complicated. I don't think they're very patient friendly, but they are still what they are. So primary angle closure suspect, that's when the iris is touching trabecular meshwork in at least 180 degrees, but there's no harm that's come from it. The pressure's normal, there are no adhesions, peripheral anterior synechia, there's no glaucoma. So it's just someone's anatomy. Then there's primary angle closure, where that has started to cause a problem. The intraocular pressure's raised, they've got these PAS, these adhesions, and then of course that can eventually lead to glaucoma, where there's actual cupping of the optic disc with a visual field defect. And this is a spectrum. Now, rewind 7 years, 6, 7 years, laser iridotomy was recommended for all of those people, no matter where you ended up on that spectrum. If you just had narrow angles, they're like, you have to have this laser. And the thing that changed this is we now realize that that anatomical variant's actually very low risk. And this was another landmark trial. This was called, great study acronym, ZAP trial. And this recruited people with that, just the anatomical variant, the iris is touching trabecular meshwork, but no other problem. And they got people like that in China, in a province that begins with Z, that's why it's that angle closure prevention study, and randomly chose one eye to do a laser iridotomy and the other eye leave alone. Follow up for 7 years. Does the eye that have laser, did that fare off better than the eye that didn't have laser? And the answer is, here, it did. The eye that had laser was less likely to reach an endpoint than the eye that didn't have laser. But this endpoint was quite soft. It included just the formation of these adhesions. It wasn't vision loss. It wasn't bad glaucoma. But also, if you look at this axis, this is 2%, 4%. If you halve a very small risk, the actual change in risk is very small. So should we be firing lasers at all of these people when the actual benefit you're doing is that small? And actually the answer is no. And so in the NHS, we are not doing that. Privately, I discuss it with the patient, and it really falls down to what the patient feels. And there are certain factors which might make you more likely to do laser. So within the NHS, we recommend if people have very high hypermetropia, so that's +6 diopters or more. If they live in a remote area, so if they got acute angle closure symptoms, which we've defined here, because it's lots of people think they might have acute angle closure symptoms, and it most often isn't. So we've said seeing halos around a light, eye pain or headache, blurred vision, red eye, nausea and vomiting if you have at least 2 of those for at least an hour on one side, then that counts as potential angle closure symptoms. But if you get that and you can't get to an ophthalmologist urgently, then maybe you should have a laser iridotomy. Then also people who might need to be on certain medications, which we'll come on to, which can trip people into angle closure. People who need to be dilated regularly, like diabetic patients for their diabetic eye checks, then you might have laser. But other people, you then have this choice. You can just accept your very low risk of angle closure and not need to have the laser. And so we wrote this patient information leaflet at Moorfields to give to this really rapidly growing number of people around the country who are walking around with this anatomical predisposition and not having laser, and this explains it all to them. So that's the QR code if you're interested in that leaflet. Now, the other end of the spectrum, those are the people who are really at risk of losing vision. And angle closure glaucoma, you can become blind from it much quicker on average than open angle glaucoma. And the treatment for this has changed, and they can benefit from lens surgery. And this was the EAGLE trial, another landmark trial published in one of the best journals. And this took people who had either angle closure with glaucoma, so they've got visual field loss, they've got cupping, or they've got very high pressure, pressures over 30 as a result of this angle closure. And they randomly either did laser iridotomy and took the treatment on from them, or did lens extraction surgery. And these people didn't have cataract, so they weren't about to have cataract surgery anyway. If they were, you just do the cataract surgery because that opens up the angle and you've solved all problems. But if they don't have cataract, the question is, do you go and take out a clear lens, put in a lens that might be less visually good for them, just to treat their angle closure? And this was another randomized design. And at 3 years, the results were quite clear. The people who had this clear lens extraction did better. They had a better quality of life. It's a bit weird, probably because there was lots of hypermetropes you were doing free refractive surgery for. Or they also had a lower intraocular pressure, and it was seen to be more cost effective as well. But again, our patients aren't averages. They aren't all the same. Is doing lens extraction always the best thing to do? So when I have a young patient who's still got accommodation, in that situation, I talk very carefully about this. And quite often we might opt to do a laser iridotomy if they're visually asymptomatic and they've got accommodation. Anecdotally, doing a multifocal lens or something similar to that in these young patients when they don't have cataract and they've got still really great vision, they can be quite unhappy. So similar to that with emmetropes. And then there's this grey line. What if their pressure's raised, but it's not up to 30, as was in the inclusion criteria for this study? And these are patients I would say it's definitely not appropriate for. So people have kind of taken these results and said, now I'm going to do lens surgery on anyone who's just got narrow angles, even if they don't have high pressure or glaucoma. And that's definitely not indicated. Okay, so the 5th edition is already old news. So I've been involved with a lot of amazing European colleagues in helping to write the 6th edition. So I can give you a little preview of what will be in there. And one randomized controlled trial, again, this is what we're focusing on, that missed the last one was TAGS, the Treatment of Advanced Glaucoma Study. Because for a long time, people said, well, people come with really bad glaucoma, they just need a trabeculectomy. Why are we giving them drops and doing this and that, and then eventually doing the trabeculectomy? And probably all the drops have irritated the conjunctiva so much, they do less well with the trabeculectomy. So it was a question, important clinical question we had for a long time. So they got people with advanced glaucoma, randomized them to trabeculectomy first, or drops first, and they were allowed to go through the drops and eventually have trabeculectomy, of course, but it was just, what do you start off with? Again, quality of life had to be the main outcome, and that was the same for both, actually. So you didn't ruin people's quality of life by surgically intervening. But at 3 years here, the intraocular pressure was lower, substantially lower at 2 years, which you'd expect. Trabeculectomy is really good at lowering the pressure. But then the 5-year results came out. So everyone was a bit confused then because there was only IOP a bit lower, but who cares if the IOP is a bit lower as long as they could still see. But this is now the 5-year results, which are recently out. So the lower IOP extended was still there at 5 years. But now the visual field, it would remain preserved in the people with trabeculectomy, but those with medical management, it got worse. And at 5 years now, there is evidence that if you do trabeculectomy first, then that might be better for patients. So this you might start to see a change in practice here. And I was a bit worried about this. In 2-year results, one of the only differences was the visual acuity was slightly worse in the trabeculectomy group. But actually at 5 years, they couldn't find a difference. Now, in my practice, I do offer trabeculectomy early on, but like I just had a patient yesterday who I thought, for multiple reasons, including their ancestry and the health of their ocular surface and everything, I just felt if I was going to do a trabeculectomy, there was quite a high chance it would heal closed. And he was initially put on drops and had this stunning response. And so for that patient, rather than put them through surgery that I think had a lower chance of success, and we already know the drops are working so well, I took a different decision. So again, these studies tell us what's best to do on average, but we need to think about how we can best care for individual patients. Now, one of the chapters that I was leading the editing on for the European Glaucoma Society guidelines was intraocular pressure measurement. And I'm quite passionate about this because I think we've kind of fallen behind the times because of dogma. So if we showed someone outside of our field these instruments and told them, which do you think is the best at measuring intraocular pressure? I bet you none of them would say this tin can in the middle, yet we still call this the gold standard of intraocular pressure measurement. And I'll give you some reasons now why I don't think it is anymore. I mean, one thing, I hate patients going home with fluorescein running around their eye. We're not allowed to use these anymore. We have to use the disposable prisms. And not only is this not sustainable to have all this plastic waste, but the Myers are terrible. And I don't know how you can get an accurate endpoint with Myers like that. In fact, the last time I saw good Myers was in the logo of the European Glaucoma Society, which I think is false advertising now. This is a colleague. He's a glaucoma specialist in Portsmouth, and we trained at the same time, and we went on this course that taught you how to use the slit lamp. And so I did, my first intraocular pressure measurement was on him and his on me, and it was Goldman we used. And this photo is misleading. He's normally like this. He's got really narrow palpable apertures. Trying to do an accurate Goldman on that patient is a nightmare. It's not, and we've got such elegant equipment now. For any patient with a narrow palpable aperture, this gives you, in my opinion, no doubt, the eye care. I like it. Yeah. Yeah. Yeah.
How do you feel about too much pressure on the lid? Say that again? Question. How do you feel about holding the lids, measuring with the eye care without putting too much pressure on the globe?
Yeah. So I would ideally try not to. And that's one of the nice things with the eye care, because it can just about get in. But there are some patients who will just close their eyes. So if you can't get any reading, then I think do it. But then it maybe make a note, had to hold the lids open. Because even if you press on the bone and you think you're not doing anything, Jane would probably tell you about the ocular tissues and maybe pulling on something. It might well change the intraocular pressure. So, yeah.
So next question.
Yeah.
Is with the eye care, it's best to get that measurement right in the center where you get to the pupil, right?
Yes.
So if it's slightly below, you get, in my experience, you get a much lower measurement.
It can be off. Yeah, not necessarily
seriously
lower.
off, right?
Yeah.
So it has to be absolutely central.
Ideally, yes.
Yes.
And you can do it more than once. And obviously it's got a thing where you take it 6 times. And if it's varying, then it knows something's not quite right and it will tell you that. Yeah. And that's one thing I like about it. It will then tell you it will tell you the number and you don't have any way of influencing it. This is an esteemed colleague of mine who said when he needs to get out of clinic on Friday, the pressures are never over 14. And I had the, consciously or subconsciously, you know, I like the idea that something's really objective and it gives you a number. And how could it? We all think that we do this so carefully, we'll get the exact same number. What is the agreement between two ophthalmologists? This is the best study on it, by the way, done by an optometrist researcher at Moorfields Arch Architecture, ±5. So if I did a Goldman, Jane did a Goldman, we could be 5 out. Yeah.
I had somebody recently who had been seen at Moorfields, and the pressure reading I was getting was about 4 or 5 millimeters higher. So you're just confirming that the variability.
The variability is huge. Exactly. Well, yeah, was it on a Friday afternoon they were seeing them all?
Can I ask one little question that came
Yes.
up today? If someone's wearing a soft contact lens,
Yes.
can you do an eye care tonometry through the lens or not?
So I've realized in the past that sometimes people have been doing pressures through lenses and the pressures have seemed reasonable.
They seem very normal.
But there has been one patient, and I remember that this was when I was still a fellow. This patient, I can't go into too many details, but I think she slightly used to, it's a very unfortunate situation, used to make up problems. She used to pretend she had fits, pretend she had, she was bedbound, yet she was young and there was no real reason why she was bedbound. She also had lost vision in one eye and had potential glaucoma in the other eye. And I always thought that maybe she was in some way misleading us. It was a horrible situation. But then I heard that she was an inpatient at St. George's Hospital with pressures in the 50s and 60s. They couldn't get it down no matter what medications they gave her. And she was going to have urgent tube surgery the next day. And the consultant I was working with said, can you just go check this patient? It sounds a bit odd. And I went to check her. And I said, have you been taking your contacts out when they've been doing that? And she said, oh, yes, I have. I said, okay, do you mind if I just do it once more? I took out the contact and her pressure was 5 because she'd been given all of this other stuff that put it down. And bizarre. And so she ended up not going for surgery. So for some types of lenses, and I think that lens was soft, but it might have been a particular type of soft lens. So I would say try and remove them.
So just adding to that.
Yes.
So me and Prav will kind of agree. Is if you've got a really thin soft contact lens on the top, in theory, it just increases the corneal thickness by microns or so. So we're expecting the pressure to be slightly higher, perhaps. Or do you think it's the tensile situation?
This is the thing. It's like corneal thickness itself. It's about the stiffness, and you can have a thicker cornea if it's a bit more edematous, and that actually you underestimate the pressure in the eye because it's more spongy. So I think it's all to do with So I look, anything we do, we're off. Right, we're just estimating it, and we need to do the best we can, and I'll come on to that, to how we can best measure the pressure. So with Goldman, we're not doing a great job between ophthalmologists, and we're moving to technician-led clinics, and that's even worse. And the problem is with the Goldman, there's no quality metric. Someone's written down a number, but if that patient was screezing, it was difficult, there's no way of quantifying that. Yet there are more modern tonometers now which give you quality scores. So the ocular response analyzer will tell you how good was this waveform. Did it catch the tear meniscus? Did it catch the lid? Or was it a good quality score? Which in the setting of you looking at values that someone else has been generated elsewhere is really helpful. Now this is what you were saying, it's got to be central. This is a new machine called the Tonovera, which you don't press a button like the eye care to take the measurement. It automatically takes the measurement, but only when you've perfectly aligned it perpendicular to the central cornea. I've only ever used it in an exhibit center, and I found it a little bit more difficult, but the CEO's promised to send me one, so I can.
Is that the one we're going to get, Anthony?
It isn't. It isn't. I'll come on to that one. So, but that gets over at least the concern that, you know, it might not hit the centre of the cornea. Cost is obviously an issue. And while there's an upfront cost for some of these devices, like the ocular response analyzer, of course, Goldman tonometry and eye care have a lot of consumables. And if you see 100 patients a week after 10 years, this is the difference in cost. Huge cost savings after putting in that initial investment. If you see 300 patients a week, the cost difference is massive. Now, as I said, use the eye care quite a lot. Like if I want to recheck a patient, if I'm doing manipulations pre and post suture adjustment and trabeculectomy, I use the eye care. And then someone said, wow, that's expensive. They cost £1 a probe. And I was like, okay, let me double check this. So at Moorfields, it's £90 for 100 probes. But for Goldman, well, the disposable tips are cheaper, but they're about 60p each rather than 90p each. But you need fluorescein, you need a good anesthetic. And if you use 1 minim per patient like you're meant to, then it's double the cost to do Goldman tonometry than eye care tonometry. So Goldman is the most expensive tonometry, and that's not considering the cost of needing a slit lamp, this footprint that takes, the space, and then the time it takes to get a patient on a slit lamp to do it. Just briefly summarise it, we talked about it already, the biomechanics of the cornea affect our intraocular pressure measurements hugely and more than we can generally estimate. And just looking at the central corneal thickness is not enough. And so we want devices that try and take that into account. So this is the one that I've got most experience with, the ocular response analyzer, non-contact. And rather than just making one applanation like that, it keeps pushing the cornea in and measures another applanation pressure on the way out. Those are at different pressures and tell you about the springiness, if you like, of the cornea. You don't need to know that formula. The machine then gives you a corneal compensated intraocular pressure, which you don't need to think about corneal thickness or anything else, but this is closer to the true intraocular pressure. And that's what we will be getting at Clinica. And there's tons of studies. This is looking at one of the biggest studies of glaucoma progression in the United States. They looked at all of the parameters, and this IOP parameter explained more than twice visual field progression than Goldman or eye care. But the problem with those clinical studies is the intraocular pressure affects how you treat people, and then that affects the progression. So let's go to our beautiful UK glaucoma treatment study where everybody was on the same treatment or all on placebo. What best predicted who progressed? Well, it was the corneal compensated intraocular pressure. The next best was Goldman, but you had to add in another parameter, corneal hysteresis, which I'm not going into today, which also comes from the ocular response analyzer. So, I mean, this on its own was great. So in summary, Goldman tonometry disadvantages, very affected by corneal artifact. You need drops. It's difficult. It needs training. It's really hard in people with narrow palpable apertures. There's no quality metric. It's poorly reproducible. There's loads of plastic waste, and it's the most expensive tonometry. What are the advantages? Are there any? People are used to it. It's the historic measures. People don't like change. But we have changed. Actually, in Moorfields now, our standard tonometry is ocular response analyzer in the glaucoma service. They all get that. And if anybody rechecks it with Goldman in my clinic, they get told off. They're allowed to recheck it with the eye care. Just to say, Goldman was great. I gave a lecture in his auditorium and sat in, they call it the Goldman throne. Goldman was a genius. And this, 70 years ago, was cutting-edge technology. But that was 70 years ago. I think it's time we break the dogma that it's the gold standard. We need to banish it to the Ophthalmic Instrument Museum. This is the one at the Institute of Ophthalmology. And I found a really nice place for it on the shelf here next to the Schiotz tonometer. Okay. But let's see. So the new EGS guidelines, too many of my European colleagues are still very, very fond of this. but there is going to be a step change towards that for sure. So you'll see that. Other things that we need to change, perimetry's got to stop being about putting your head in a bowl these days. I did this, it's amazing, the tempo, it's not available in the UK yet, but I was in a busy exhibit centre, and you keep both eyes open, you don't have to cover one eye at a time, very comfortable. That sort of blocks out everything else, very easy to use. And I get Humphreys regularly because my mum's got glaucoma, so I know that was great. I know patients are going to love this, and I can't wait till we've got it available. Okay, let's move on to medications, which I've got until 7:45, right? Okay, I better speed up a bit. So we all know the glaucoma medications. The prostaglandin analogues help fluid out, not through the trabecular meshwork, through the other way, the uveoscleral way, and pretty much all the other commonly used drops reduce the amount of fluid the eye makes. And that's how we lower intraocular pressure. Hardly anyone uses parasympathetics anymore, but this is the new kid on the block. Finally, first time in 25 years, we have a new class of action for glaucoma, HARLEY, Reclanda, and that's latanoprost plus the new one, nitacidil. So it's only available in a fixed dose combination. What is nitacidil? It's a Rho kinase inhibitor. That works on, they market it actually as just working on trabecular meshwork, but some research that we've done that does suggest actually it's not only opening up that, it opens Schlemm's canal, it opens collector channels, it opens the episcleral veins even, and helps lower pressure that way. So that's exciting. It's once daily dosage, so that's helpful. But one of the exciting things is it's a complementary mode of action. Because otherwise, before, when you're on 2 drops and you're adding in other ones, they're trying to do the same thing, and the extra drops don't do much. They cause more ocular surface disease, I can tell you that. So that's why it seems, studies seem to show it can work well even when people are already on multiple other drops. The other thing, because it lowers this stuff beyond the trabecular meshwork, it seems to be able to get the pressure really low, whereas most other drops sort of have this floor effect. It does have side effects, and the big one is red eyes. And I think that's through its mode of action. It dilates, it opens things. You can get this corneal verticillate. It's these lines in the cornea. I'll show you a picture, but that's reversible and rarely visually significant, and itchiness and allergy. This is what they look like when you look at them on the slit lamp. They've got these dilated vessels and these small, tiny hemorrhages as well. And I think that just shows how it's working. And you can see that there as well. That's the corneal verticillata. It's been approved by NICE. That was hard work. So I was one of the clinical experts for that. But unfortunately, there's a whole other process that needs to happen to that for that to be available everywhere. So there are still some people who are finding that their local commissioners haven't put it on the formulary so that they can get it from their GP. But they can get it from Moorfields, and we can prescribe it from there. Prostaglandin, I think, given the audience is mainly optometrists here, I'm just going to go through just high-level stuff. So you're probably aware of most of these side effects. One thing I just like to remind my juniors when they come through the clinic is beta blockers, very well tolerated on the eye, but can have systemic effects. It really can slow down the heart rate. And a number of patients in my career have gone on to have investigations and maybe even pacemakers where people haven't twigged that actually it could be a little old eye drop that's slowing down the heart rate. Carbonic anhydrase inhibitors, there's the ones that sting. Patients will often say these are the drops that I'm allergic to, but it's actually often the alpha agonist, but they feel it's this one because they sting when it goes in the eye. Alpha agonists can have surprising effects. They cross the blood-brain barrier. They can make people quite tired and can quite change mood. And the thing I always say is drug reactions can be individual. So when a patient says, this is happening to me with this drug and it's not been mentioned before, of course you believe them and try stopping the medication to see if it improves. Of course, caution in pregnancy. This was just a case report We wrote in the Lancet, trying to tell the general medics, beware, these combination drops, if someone tells you they're on Combigan, it doesn't say OLOL at the end, which tips them off that it's a beta blocker, and that physicians need to know these combination drops may contain quite high doses, actually, of beta blockers. Now, what about systemic medications that people are taking for non-eye things that can influence the risk of glaucoma? We know that steroids really can cause, in up to a third of the population, the pressure to go up in the eye. And it's more likely to do the closer it is to the eye. Injections into the eye are worse than drops, are worse than taking tablets. And that's well established. What medications can reduce open-angle glaucoma? Beta blockers, which are often taken as tablets, can profoundly, as a tablet, can profoundly lower the intraocular pressure. And that needs to be taken into account. So someone with suspected glaucoma with normal intraocular pressures, if they're on beta blocker tablets, it might be masking their physiologically high pressure. Angle closure, acute angle closure, these are the classic ones they cause a pupil block. Dilating drops, drugs for urinary incontinence, for muscle spasms, for asthma and airway diseases, and some of the antidepressants. These are without doubt, patients when they have this, they can come in even with angle closure in both eyes. Then there's the odd ones, like topiramate, which causes this kind of rare reaction in a small number of people where the choroid swells and pushes everything forwards. There are tons of medications that are implicated in angle closure. You've probably had lots of patients coming to you saying, I'm about to start this medication, but it says don't use in glaucoma. It's pretty much always been referring to people with angle closure glaucoma who don't have an iridotomy or who haven't had cataract surgery. This is a review we wrote in JAMA, again, going towards the general specialists. And look at this long list and stuff that is in cold and over-the-counter cold and flu preparations. Do we tell all these people, do we tell people who have got narrow angles that we're not doing laser on to avoid all of these? Well, we took the decision actually to not do that. And we've just put, again, on this leaflet, and it's free to download, we have the list of medications we think we should pre-warn patients about rather than that longer tentative list. I think that might, okay, let's just
Anthony, don't worry about time. We're all absolutely fascinated.
Yes.
Carry on, please.
Carry on. Okay. This is just, because I think there's a lot we can learn about diseases by looking at patterns between people who use these different medications for other conditions and what their risk of glaucoma is. So this is tons of data from people in the US, and we looked at, if people are on certain medications, do they have a higher or lower chance of having glaucoma? And just to say that 3 really popped out. I was really pleased to see beta blockers there with a reduced risk to the left of the line, because I thought, yes, our study design worked. We expected that, we know that. But then there was this odd one here, calcium channel blockers, and this type of antidepressant being protective. Now, sadly, we've never been able to replicate that one, but every study we look at with calcium channel blockers, those is associated with a higher risk of glaucoma. Now, it's not far from proven. It's an area of intense research, but it might be in the future we realize that this particular common class of blood pressure medication, most commonly amlodipine, may actually be contributing towards glaucoma risk. Okay, minimally invasive glaucoma surgery, MIGS. And I wanted to focus on today, just briefly, the ones that are truly minimally invasive. Lots of things are called MIGS now that are actually quite invasive. But the real minimally invasive ones are things like this, which is the eye stent. This is a tiny little stent. So this is trabecular meshwork. At the end of cataract surgery, it gets filled with blood, so you can see it really easily, that red line. And then this thing is tiny. I've had to explant them before. And you put it on a swab, and then you can't say, did I put it there? And it's really a tiny fleck. It's incredible. And if positioned well in the correct place, can actually have a pretty good effect on intraocular pressure. My preferred one is this, actually, the Hydrus microstent. It's bigger. The reason I like it is it stents open Schlemm's canal, and it's got this lovely system where you just you just put the cannula just under trabecular meshwork and you roll this wheel. And look, it introduces this device. You can see the windows coming in here into Schlemm's canal, stents it open. And therefore, when fluid flows through here, you know it's got a better chance of finding what's called a collector channel beyond that. And there's a study comparing the two, and this one wins out. But I think they're both pretty good and both pretty minimally invasive, as long as you're doing it at the same time as cataract surgery. Obviously, if you're going in to just do this, then you're opening the eye and there's all of the risks from that. But if someone's having cataract surgery anyway, I'm definitely an advocate of, and I said pre-op assessment, I think anyone who's on glaucoma medications or maybe about to go on them, I think it's a real shame if you don't have one of those stents at the same time as cataract surgery. And there's growing evidence now that it can help preserve the visual field. It can delay the onset of needing more invasive surgery. Then there are the MIGs, which are, it's not as invasive as trabeculectomy, but here so here, it's so cool. You put this cannula into Schlemm's canal, and it's got a flashing light to check you don't deviate out, but you then put it all the way around Schlemm's canal, and then it pokes out your initial hole again, and then you can pull it through like that, so you can rip through the whole of trabecular meshwork. Now, in patients who have their problem primarily at trabecular meshwork, this can have a really stunning result, but you've made a cut, and that, rather than just a stent, that's more invasive. And my worry is in the longer term, well, you don't know what that response to that cut is, and they could heal, and then they could be worse off than they were originally. So I save this for people who are going to need a trabeculectomy eventually anyway, and this can maybe buy them time, and in some people it lasts a long time. This actually was a UCL professor who had pigment dispersion syndrome, so very much thought that the disease is stuck at trabecular meshwork. And he had a stunning result, which lasted about 2 years, but now he's needed something else. Now, this is less minimally invasive. This is more invasive, and it's a great new innovation called the PreserFlow microshunt. So trabeculectomy, rather than having to hand fashion a trapdoor, get the stitches just about right, but then adjust them, seeing them weekly in clinic, it's a device that's a flow regulator that we put in, and it makes the surgery quicker. It means you need less manipulations after the clinic, and it's much more predictable. But it's really, almost as invasive as a trabeculectomy. So while it's a modern innovation, and some people put it under MIGS, it's not really minimally invasive. And this is something we could maybe talk about. So this is actually thinking, what should we do at the next education thing? That's one thing. Can you talk more about the minimally invasive and other newer inventions surgically if you're interested? The other thing, shall we do an OCT workshop? This was a patient I saw on Monday. Well, actually, an optometrist in my clinic saw them on Monday and said, I think something funny is going on here. And I said, I agreed. And this patient has pathology in their occipital cortex. They've got multiple myeloma. The PET scan did show potential thing on the back of their skull, and this shows that actually it's affecting their occipital cortex. Another thing is, it's maybe a bit more in the research field, but it is coming into the real world, and that's genetics. And if I had your genetic codes, I could predict whether you're going to get glaucoma or not in the future quite accurately. But your patients have access to it now. This is my report from a direct-to-consumer, and it's telling me my genetic risk of glaucoma. And for people that have it up here, the most important thing they do is see you at least once a year. And then knowing, what are the things you can do to minimize that genetic risk. And that brings in another thing we can talk about, which is lifestyle, because this has become a rapidly evolving field. For years, we weren't finding anything for glaucoma. Now we know quite a lot. So that might be something you're interested in. The other one I was going to say, I don't know whether it's very researchy, but might be relevant for GPs and for optometrists, is how can an OCT scan affect management of general health? Because with the eye as a transparent organ, we can take amazingly precise measurements of blood vessels and of nerves. And we're showing more and more now that that relates to prediction of cardiovascular disease, cognitive health, and so on. And I know small groups of optometrists, some of the very big groups of optometrists are excited about this area and what role will community optometry play in terms of linking what the OCT scan will show to informing what further tests should you have, what should you do for your general health. So if you're interested in that, that's another talk we could talk about. And another thing we could do. And lastly, I just thought this is a brand new thing, and I don't know whether there'd be any interest in this, but I thought I'd start a WhatsApp group so that if any of you have a query, if you see something weird on an OCT, or you say, I've got this patient, what do I do with it? If you wanted to put it on WhatsApp, I'm normally quite quick at answering, and maybe we'll put some other people on it for glaucoma queries, then you know, it's just as a kind of a forum where you can have questions answered, then I'd be delighted to do that. Now, it's only 6 minutes over.
Thank you so much, Anthony. That was a wonderful inaugural lecture, and we're delighted to have you again to say at Clinica. I forgot to say at the beginning, your journey has taken you from Cambridge to Harvard to London, maybe not in that order, and you've picked up an enormous intellectual knowledge about data, but you managed to relate it to the patient in front of you and make sense of it. So thank you very, very much. I'd like to open this now to questions from the floor. Anyone who is here in house want to ask some questions? Or are you all flabbergasted?
On behalf of all of us, we'd like to say it was a fabulous talk.
Oh, thank you.
We really enjoyed it. We learned so much.
Good.
Absolutely fabulous. And thank you so much. And we're all joining the WhatsApp group. Unlucky you.
And we also have questions from the online people. So I'm just going to go back to the chat and read those out as well. How do we join the WhatsApp group? Take a picture of the QR code, yes?
Yes. And the other thing, I don't know, do people register with their email address?
Yes, they do. So
and
we
then
have...
you can send, I can give Isabella this, and then you can email it maybe, or something.
And they can also email into academy@clinicalondon.co.uk. That would be fine.
To get the, yeah.
To get it, yes. And then Isabella will reply to them directly. Point your phone camera at the QR code and it will go directly to it. Yes. And a lot of thank yous from everybody. We'll write that email to you, people who are online. We have all your emails and we'll make sure you get that link to the WhatsApp group. So that's the glaucoma queries for Clinica that Anthony will be rapidly replying to in the future. So thank you for setting that up. That's great. Any other questions from the front here?
Can I ask you guys? What, oh yeah, no, we've got a question.
Yes. One question over here.
Can you tell us for patients who have atrial fibrillation, is there an increased risk of glaucoma, and is there anything specific we should be looking for?
As far as we know, no. And that's one of the things I've done research using big data sets. What are the links between different systemic diseases and that? So it doesn't come up from atrial fibrillation. Actually, a lot of them get systemic beta blockers. So if anything, I would hypothesize they might have, for an age-matched person who doesn't have it, they'd be more likely to be on a beta blocker and maybe a lower intraocular pressure and less likely to have glaucoma. Yeah. But they can obviously, the thing they can get is amaurosis fugax, and then potentially a stroke, which amaurosis fugax could herald. So because of the irregular heartbeat, they can develop a clot. And if they're not adequately thinned in terms of the blood thinners that they're on, that clot can go up. So that happened in my glaucoma clinic about 4 or 5 months ago. It was one of those things where he forgot to tell me. At the beginning, I always asked, anything new to report? Nothing said, went through the whole consultation. You're doing great. And as he left, he said, oh, I meant to tell you, this strange thing's happened a few times where the whole vision went black. And really? Talked through a few things. And actually, because of one reason or other, they'd stopped his blood thinning medication. And so we immediately got in touch with that practice. They went in, they did an echocardiogram, he had a clot in his heart. So, you know, and who knows when he might have developed a stroke or whatever. So atrial fibrillation, I guess the thing with the eye sign is vision going completely black.
Another question from online. What if the eye pressure drops too low?
Yes. So, really fortunately, out of the hands of surgeons, the eye pressure rarely goes too low. That patient I said on the ward where they were throwing all the medications, their pressure only went down to 5. The time it goes too low is following surgery. Most typically, trabeculectomy is the one where it can go too low because it's just not a very predictable procedure. So that's one of the advantages of the PreserFlow microshunt. It's less likely to go too low. It's safer for the patient. What I want for glaucoma surgery is cataract surgery has become just so brilliant and predictable for everybody. I want glaucoma surgery to be that good too. And I think in recent years, we've made some really good advances towards that. But too low pressure is bad for the eye too.
Another question from online. Would Goldman applanation be a must before we refer for glaucoma if we have checked with the IOP with the eye care?
From my point of view, I would be more interested in the eye care readings. But unfortunately, that outdated guide I showed you before from 2016, before I had my current knowledge, that does say that the best referrals are from slit lamp mounted applanation tonometry, which means Goldman tonometry. But we need to move away from that. I think the new EGS guidelines will start to move away from that. Anytime I next got an opportunity, be it with NICE, be it with the Royal Colleges, to change that, I think we need to change it because it's almost a bit, it's become a dogma.
Very interesting question here. What are the advantages RHO kinases?
Of Rho kinases?
Yes, Rho kinases.
So I think the advantages are the once daily dosing, because once you've done latanoprost, let's say you're asthmatic and you can't have the beta blocker, everything else you're going to add to get the full effect has to be 3 times a day, whereas now we've got something that comes combined with latanoprost, 1 drop once a day. That's an advantage. The other advantage is this is a new mode of action at last. So all our others were essentially doing one of 2 things, but now you've got something that you can add in that's different to the other 2, so you're more likely to get an effect when you're already on medications. The other thing, and I have found this, if patients already got quite a low IOP, SLT, we talked about that, that doesn't work. Lots of drops struggle to get it lower, but actually this drop seems to work better even with lower IOP. So those are the main advantages.
And would you take the Rho kinase at night or in the morning, or no particular recommendation? So
interesting. So for prostaglandin analogues, they say at night time, but actually it doesn't matter when you take them. And it's actually the same with the Rho kinase inhibitors. It doesn't matter when you take them. The reason they decided, and there's still one of the guys who was around the table at that initial time, he shared the story with me. The reason they did prostaglandin analogues last at night was because people get a red eye, and if that then subsides overnight, they'll be less symptomatic with it. And that's actually particularly the case with Rho kinase inhibitors. So I would say take them last thing at night. The one to not take last thing at night is when a prostaglandin analog is combined with a beta blocker. So some people seem stuck. Well, I took my latanoprost at night. Now I'm taking latanoprost together with timolol, be it Fixapost or Zalacom. I'm going to do it last thing at night. Bad idea for 2 reasons. One, beta blockers are an aqueous suppressant. The time you make most aqueous by far is when you first get up in the morning. That's why most people have the highest pressures first thing in the morning, because that's when you're producing most aqueous. If you're taking your beta blocker last thing at night, you're missing that whole day. It needs to be first thing in the morning. The other thing is, we know it's systemically absorbed. Your blood pressure goes down overnight anyway. You probably don't want it going down even more. And that's why most tablet antihypertensives you take first thing in the morning as well.
A very interesting question here. Do you believe that quickly progressing glaucoma that marches on regardless of treatment and often seen in younger African patients is not actually glaucoma, instead another condition that looks like glaucoma?
So I would say that glaucoma isn't one condition, and it's lots of conditions that initially look to us the same. And we try and work out, well, I think this type of glaucoma is going to be more aggressive or not. And we're still not that great at doing it. I like giving pseudo-exfoliation as an example, because that's quite a subtle finding, right? And if nobody had picked up on that, we'd be treating it as primary open-angle glaucoma. But we know pseudo-exfoliation gives a much more aggressive form of glaucoma. So I think there are other forms. The form that I think marches on regardless, I don't know, I'm not so much about young patients with African ancestry. I find if you do good tube surgery for them, you can often stop progression. The patients that really progress, that we all see, I think, are the so-called Flammer syndrome. That tends to be women, aged, say, 50 and older, who tend to have low blood pressure, and let me get this right, who are slim. I told a patient of mine the other day who they were thin and she was upset. No, exactly, sorry. So I learned something. So slim, low blood pressure, women, and cold hands and feet, maybe sleep disturbances. And it's amazing. You see the people come in, they've got pressures of 12, they've got glaucoma, you start treating it, you struggle to get the pressure down and they're getting worse and worse. And, you know, I now ask a lot earlier than I did earlier in my career. Do you happen to have low blood pressure? Oh, I'm always told I've got low blood pressure. Do you get, terribly cold hands and feet? They're very challenging. The question is, do you do surgery as invasive as trabeculectomy to get the pressure low enough? One thing you can try is acetazolamide, actually, which is horrible to take in the long term, but of course you stop it and the side effects immediately stop if you can't tolerate. And you can trial for a period much lower intraocular pressure and ask the patient, do you think you're stable or do you getting worse? And that's a useful trick.
If you can take one more question.
Yeah, it's me.
Are iridectomy still done at superior iris or temporal iris, and why?
Okay, so the iridotomy, which I showed a picture on, a laser iridotomy, was temporal. And I think you can do it superior temporal. At Moorfields, we went to temporal on the basis of a randomized controlled trial that showed you're less likely to get the visual disturbance there. Now that seems, why is that? Because surely the upper lid would cover it in the position at the top. Why are you, if you make it in the interpalpable, so surely more light's going to get through it and you'll have more symptoms. It's because if light goes directly through it, it doesn't hit a part of the retina that you're aware of. For the upper lid, the only way it goes through it is if it hits the tear meniscus and it goes through, it has a prismatic effect and it ends up going through the iridotomy in a different angle, and then it hits a part of the retina that you do perceive, and therefore you get symptoms. And actually, you should never say this, but I'm going to tell you, I don't think I've had a single patient with a problematic vision problem after iridotomy since I moved to doing it temporarily. There are disadvantages. The ciliary body, a process tends to come out and rotate behind it, and it makes it hard to transilluminate. So sometimes it looks like it's not patent, even though it is patent, which can then cause other people who see your patients think, oh, I don't think the iridotomy is patent, even when you know it is. So that's the only disadvantage.
We're going to take just two more questions from online. The first is if SLT is deemed a first-line treatment, do you foresee this being performed by suitably trained community optometrists in the future?
100%. I trained, there was an optometrist in my clinic, and I trained them up because we need help to do the SLT, so absolutely. Now I've got a lot of American colleagues, and I'm sort of quite politically involved in the US, and they generally would very much disagree. That optometry and ophthalmology don't seem to get on very well in the US. There's these scope of practice battles, whereas in the UK, and I keep on saying this, we've got a great relationship. And I think we want treatments that work to be delivered most easily and most widely and most fairly to everyone. And we need help to do that. And I think as long as people have had the training and you audit your outcomes and you're doing a good job, then we should. Now, coming out, is direct SLT. There isn't much data on it yet, so I want to see the data, but this is where in just under a second, I think, the whole SLT is delivered. It's delivered through the sclera, so you don't even need a contact lens, and the patient just sits on a machine a bit like a slit lamp, and it does it. It apparently works quite well. Apparently it doesn't work as well as the SLT we know, but pretty good. And for me, if that can be delivered, and we can deliver that in community optometry, then that will be a big win for our patients.
I'm sure you're right, because with the increasing population in the UK and more older people, we're going to need all the help we can get.
Absolutely.
Yeah. The last question, and it is, what about patients who are asked to check for glaucoma before starting heart meds?
I'm not sure anyone's asked me to do that. So I wonder which heart meds they'd be thinking of.
Maybe it's the beta blockers.
Maybe the beta blockers.
Yeah.
Well, I don't mind. As a glaucoma specialist, beta blockers lower the intraocular pressure. I had a patient recently who actually I diagnosed her arrhythmia. I thought she gave me a symptom, and I said, I think you need to see a cardiologist. And by the way, if the cardiologist, because she's got such bad ocular surfaces that she can't tolerate any intraocular pressure lowering drops, which is a nightmare. And so I said, I think you might have an arrhythmia, you should get it checked out. And by the way, if your cardiologist wants to give you a beta blocker tablet, I'd be delighted. And that's what's happened, and it has helped with her intraocular pressure.
Fantastic. Well, on that note, a very big thank you, and we wish you many years of future data research and many years with Clinica as well. We look forward to your next lecture. We'll ask people to feedback what they would like Anthony to talk about next time.
Fantastic.
So thank you.
Thank you all for coming. Thank you.